Over the next several minutes, we'll consider how AI, especially the deep learning approaches, might be applied to help us. This illustrates the cognitive biases that influence our clinical decision-making. These are the major ones, and there are a lot. Of course, we're influenced by the patients we've seen previously, the diagnosis we missed, the education that we've had, and the mentors. We're also adversely influenced by time pressures, sometimes reaching a conclusion too quickly without considering all the possibilities. And fatigue and just overload of information can make all of this worse. AI has an opportunity to help us with our decision making. On the left-hand side, you can see the exponential growth of FDA approvals of medical algorithms. The largest number of these have been in radiology, but there have also been considerable growth in cardiology and pathology. And there was a recent JAMA summit that convened and came up with this as part of their report, that AI has transformed medical imaging, augmenting image interpretation, and dramatically changing how radiologists and pathologists work, with adoption of some type of AI by 90% of US healthcare systems. That's a lot. And indeed, there are solutions for us in cardiology that are available today. This illustrates the development of a deep learning model to detect HFpEF. This model uses only an apical four-chamber view. Trying to get it to play here. But this four-chamber view really contains a lot of information. You can see ejection fraction, chamber sizes, the motion of the mitral and tricuspid annulus. And all of this, we hypothesize, might allow us to detect HFpEF. So using the apical four-chamber video clip, we trained controls and HFpEF, trained the model to differentiate controls and HFpEF patients. And we define controls as patients without heart failure, including without heart failure a year after their echocardiogram. All had ejection fraction more than 50%, and the controls had normal or grade 1 diastolic dysfunction. The HFpEF patients had a clinical diagnosis of heart failure as well as elevated filling pressure on their echocardiogram, and 17% were withheld for validation. This shows the performance of the model in testing. It was tested at a separate site, separate sonographers, separate physicians, and this included a population of similar numbers of controls and HFpEF patients. The controls and HFpEF patients were matched for sex and the year of echo, and as we tried to match for age as well as we could. There was good representation of women in model development. The AI echo model classified 7% as uncertain, and you can see the performance in discrimination and classification here. The AUROC was 0.91, sensitivity 88%, specificity 82, positive predictive value 84, negative predictive value 87%. And these results are published in JACC Advances, and this model has been FDA approved. We wanted to compare the model with the clinical scores that we used to identify HFpEF. And shown here on the left-hand side is comparison with the HFA PEFF score. And here on the right-hand side, the H2 FPEF score. These scores use echocardiographic variables as well as some clinical information. But the problem with both of these scores is that they leave a lot of patients classified as indeterminate. Our AI model was able to reduce dramatically the number that were non-diagnostic and classify these patients. Then we wanted to see how well the model did for identifying patients who had heart failure hospitalization and cardiac mortality. And this is a comparison of in a separate population. We used National Death Index for the cause of death determination. This is the performance of the model for heart failure hospitalization according to the predicted group. And you can see that if they're predicted to have heart failure, they had more heart failure hospitalization. Those that were uncertain by the model had an intermediate risk. Even the data provided by the model as to the quartile, the score of the model was important in stratifying the patients. The data were similar for cause of death, for cardiac death, and also superior to clinical scores in classifying the patients. A next disorder to take on with building a model was amyloid cardiomyopathy. And of course, this accounts for some of the patients with HFpEF. And it's been estimated that ATTR cardiomyopathy is present in 6 to 17% of patients over the age of 60 with HFpEF and increased wall thickness. Here you can see light microscopy of a heart muscle, and you can see the extracellular deposition of the amyloid protein, which appears as this green-blue color with sulfated Alcian blue staining. And now that we have good treatments for amyloid cardiomyopathy, we certainly want to identify these patients early. Of course, we look at the electrocardiogram in all our patients with suspected cardiovascular disease, and sometimes this provides some clues to the diagnosis of cardiac amyloidosis. These can be low QRS voltage, pseudo-infarct pattern, and abnormalities of conduction. But actually, most of the time, these are not present. It's only about 30% of patients, usually those with AL amyloidosis, that will have these abnormalities. Echocardiography sometimes also really gives us important clues to this diagnosis. Here you can see thick walls of both the left and right ventricles. The atrial septum is thickened, the valves are thickened, there's a small pericardial effusion. Doppler assessment shows restrictive hemodynamics, and global longitudinal strain shows apical sparing pattern and severely abnormal strain at the basal and mid segments. But it's not always this obvious, and indeed these findings are not entirely specific for cardiac amyloidosis. In some patients, even wall thickening is absent. This was a series that we published a while ago of patients with advanced cardiac amyloidosis who had completely normal wall thickness. So the diagnosis is tricky, for sure. In developing this model, we wanted to consider all possibilities. We again used the apical 4-chamber video clip building on our experience with the HFpEF model. These are the numbers of patients with the different major types of amyloid that were included in model building. We also challenged the model with patients with hypertrophic cardiomyopathy, aortic stenosis, hypertensive heart disease, HFpEF, and monoclonal gammopathy of uncertain significance. That's how we built the model. We tuned it with the same cohort that we used for the HFpEF model. And then we tested it exhaustively. We tested it in a global multi-ethnic cohort from 18 sites across the world. And this cohort was really remarkably diverse. 38% non-white and 43% women were in this testing cohort. 22% had cardiac amyloid, and you can see the distribution of the different types of amyloid. This shows the performance in the entire external test cohort. The AUC was 0.93, sensitivity and specificity shown here, positive predictive value 78% and negative predictive value 96%. We wanted to make sure that the model worked well in all sorts of subgroups, and this is explained in the paper. The sensitivity was maintained for all the different major types of amyloid cardiomyopathy, and the model performed consistently across a range of demographics, including race and sex, comorbidities, ejection fraction, wall thickness, and ultrasound vendors. And this model is commercially available. We wanted to evaluate the model compared to our clinical scores that we use in a day-to-day basis to estimate whether our patients have amyloid cardiomyopathy. These include the TCAS and the increased wall thickness score. Our amyloid model did better than either of these. Here we plotted the positive predictive value, which is, of course, the probability that a person with a positive test actually has the disorder across varying prevalence of disease. And you can see across this whole prevalence range that we might encounter in clinical practice, the AI model was better than the scores. So in conclusion, we can say that AI enhances HFpEF and cardiac amyloidosis detection. It does better than the clinical scores. And there will be forthcoming, it's already well underway, evidence that AI allows us to detect disease earlier. When AI is trained responsibly, it reduces diagnostic bias and will cause more uniform detection of disease. It offers scalable and real-time support in clinical practice. And of course, we need continued research and assessment of these tools in diverse populations like yours. But we hope to not just detect disease, but by earlier detection and early treatment to actually change our outcomes for women and all our patients. Thank you for your attention.